Well, here we are back with chapter 45 and part 3 of Geriatric Emergencies. When we finished up part 2, we were talking about some cardiovascular type of issues that are related to geriatric patients. We're going to pick up there. We got a few more little things that we want to talk about in that area before we move on into neurological and then some GI issues that will round out part 3 of this of chapter 45. So let's get going. Of course, you know, we finished up, we were still talking about AAAs and abdominal aortic aneurysms as well as aortic aneurysms and those kinds of things. We're going to pick up here, we're going to talk about traumatic aortic disruptions. This is also known as aortic dissection. It occurs when the inner layer of the artery wall tears and blood gathers between the layers of the artery wall. It can be caused by trauma, sustained high blood pressure, and that's especially when an abdominal aortic aneurysm is already present, is when these things can truly become problematic. This condition weakens the arterial wall and raises the risk of rupture. Thoracic arterial dissection may cause some chest pain that mimics cardiac ischemia. Blood pressure should be measured in both arms if the patient complains of chest pain. A difference of 15 millimeters of mercury or more in systolic blood pressure between the arms indicates the possibility of a thoracic dissection. Of course, stroke, we're fairly familiar with stroke. We've talked about it pretty extensively in a previous chapter, but it's the leading cause of death and disability among older adults. More than half of stroke survivors aged 65 or older experience some form of decreased mobility as a result. Race and ethnicity are important factors in assessing the risk for stroke, and those risk factors are going to include things like hypertension, which is a primary risk factor, and then of course age, family history, smoking, diabetes, high cholesterol, heart disease, and of course we mix into that the normal aging process and those normal aging changes that go on, and those are all going to increase the risk factor of a stroke. Prevention of strokes is going to focus primarily on reducing those risk factors, improving diet, exercising, and lowering cholesterol. Pre-hospital care is going to include early recognition of stroke, identifying conditions that mimic strokes, and prompt transport, as well as using those stroke assessment tools that are available to us. Consider the patient's history. For example, an older person with arthritis may have limited movement on one side unrelated to that particular stroke. So the limited movement may not be completely stroke related, or there may already be some limitations there due to some arthritic movements or some other issues. Family members or caregivers can provide a lot of valuable information about the patient's baseline cognitive status, personality, and their ability to perform the various daily activities. Assess the patient's capacity to carry out basic cognitive tasks, and caregivers may also offer some insight into what responses are typical for this patient. TIAs, of course, a transient ischemic attack, is considered in more detail in Chapter 19. When we talk about neurological emergencies, any patient with stroke-like symptoms should be managed as if they're having a stroke. Patients who've had previous TIAs are at significantly higher risk of experiencing a stroke rather than another TIA. All right, so now let's dive into some neurological conditions, and we'll probably spend quite a bit of our time here, and then we'll round it out with some GI issues there towards the end of this part. Age-related cognitive changes are typically isolated and not linked to specific disease processes. Their onset and progression are gradual and mild without extending over other types of cognitive abilities. Delirium is a symptom rather than a disease. It is also referred to as acute brain syndrome or acute confusional state. This condition is usually temporary, and most of the time it's reversible as well as it reflects there's some kind of underlying issue going on. It is marked by disorganized thoughts, inattention, memory loss, disorientation, significant changes in personality and affect, maybe even hallucinations, delusions, and a decreased level of consciousness. Confusion and disorientation tend to vary over time. Bizarre behaviors may result from the presence of hallucinations, and there may be rapid shifts between mental states, serious disruptions in attention, disorganized thinking, and changes in perception and sensation. Symptoms of delirium can resemble those of intoxication, drug abuse, or severe psychological disabilities. Assessment and management of delirium can be quite challenging. Assess for recent changes in the level of consciousness and orientation, and include signs such as acute onset of anxiety, difficulty thinking or maintaining attention, and trouble focusing. Also evaluate for changes in vital signs, body temperature, glucose levels, and current medications. In older adults, delirium often replaces or complicates the typical signs and symptoms of medical issues, adverse medication reactions, or other drug and alcohol withdrawal signs. Causes of delirium can include medications, toxins, electrolyte imbalances, poor nutrition, disorders affecting the respiratory, cardiovascular, or nervous system, abnormal blood sugar levels, environmental emergencies, physical trauma, and infections. Neurologic and endocrine conditions are particularly important to consider and include Alzheimer's disease, Parkinson's disease, and diabetes. All of these can play a role in developing symptoms of delirium. We can use the mnemonic conveniently named deliriums that will help us identify the potential causes of delirium. Delirium stands for, the D in that stands for drugs or toxins. E stands for emotional or psychiatric causes. L would be for low oxygen levels. I would be infections, including pneumonia, urinary tract infections, or sepsis. R would be retention of stool or urine. I, again, is ictal state or seizures. U, undernutrition and underhydration. M is metabolic causes such as thyroid disorders, electrolyte imbalances, or kidney issues. And S may be subdural hematoma. This is similar to other mnemonics that we use that's going to help to kind of clue us in to remind us of what to look for and what may be the causes of deliria. Sudden onset for deliria is typically sudden and abrupt, developing over hours to days, and typically improves once the underlying issue that's causing it is treated. Treatment, of course, is going to be aimed at addressing the root of the medical condition or the disorder that is causing the delirium. Getting an accurate medical history can be difficult from the patient because the patient is oftentimes confused or even uncooperative. This is where we're going to have to rely on family members, bystanders, or caregivers, those that are present at the scene. Dementia, on the other hand, often results in permanent brain impairment. Signs and symptoms typically develop gradually over months to years and may include short-term memory loss and reduced attention span, jargon aphasia, hallucinations, confusion, disorientation, difficulty in learning or retaining new information, and changes in personality. Conditions that affect vascular and neurological brain functions can lead to dementia and include infections, strokes, head injuries, poor nutrition, and medications. The two most common degenerative dementias are Alzheimer's disease and multi-infarct or vascular dementia. Dementia may also result from brain tumors, emotional disorders, Parkinson's disease, or Huntington's disease. A person is diagnosed when two or more cognitive and psychomotor brain functions are impaired, such as language, memory, visual perception, emotional behavior or personality, and cognitive skills. Gradual decline in cognitive abilities are typical symptoms that we see, as well as impairments in short and long-term memory, deterioration of communication skills, the inability to carry out normal daily activities, increased likelihood of becoming lost or even in familiar environments, and changes in mood and temperament, especially more frequent anger and irritability issues. Most emergency calls involving dementia-related patients are new symptoms or changes, dramatic changes in their behavior. Dementia itself can't be cured, but we can treat the underlying medical conditions causing the sudden changes. Gather as much information about the patient's usual functioning and behavior from the caregivers. Specifically ask about what changes prompted them to call for EMS. Verify patient information by cross-checking with caregivers. But be sure to exercise caution when treating patients with dementia. Patients may act aggressively due to their confused and anxious state. Caregiver abuse is at higher risk since patients may be unable to report harm or neglect. To support caregiver well-being, you can recommend some home health services, respite care programs, and additional community support services that may be available out there to help those caregivers. Alzheimer's disease is the most common form of dementia. It involves a gradual decline in abilities starting with mild symptoms. Early signs include misplaced items and trouble remembering names. Difficulty with clear thinking, reasoning, problem solving, and focusing begins to develop. Later stages involve forgetting close family members and personal memories. Symptoms can include confusion, changes in personality or decision-making abilities, severe challenges performing everyday tasks, and the condition is irreversible and has no cure. The disease progresses through some distinct stages. The mild cognitive impairment is the earliest stage, called the pre-Alzheimer's stage, since not everyone with mild cognitive impairment develops Alzheimer's. Features include forgetfulness, especially about conversations or recent events, trouble multitasking, reduced problem-solving abilities, and taking longer to complete more challenging tasks. Early-stage Alzheimer's disease shows increased cognitive decline, difficulties with language, misplacing items frequently, getting lost even in familiar paths, changes in personality and loss of social interaction skills, and losing interest in hobbies or activities once enjoyed, as well as struggling with moderately complex tasks that used to be easy. Symptoms worsen significantly as Alzheimer's disease advances. They'll begin to forget recent events and parts of personal history. They'll have altered sleep patterns. They're going to struggle with reading and writing. They'll have impaired judgment regarding danger and risk, disorganized speech, and nonsensical sentences. And they'll experience hallucinations and delusions. They may even exhibit dangerous or aggressive behavior and agitation. And they'll also begin having extreme difficulty completing some of the most basic of daily tasks. Once they reach the severe or end-stage portion of Alzheimer's disease, patients lose memories from their early childhood, and they're unable to understand language, unable to recognize close family members, incapable of performing basic self-care, and they're unable to communicate verbally with family or caregivers. And they often at this stage begin to require feeding tubes and urinary catheters because they're struggling with some of the most basic of things that people do. Alzheimer's cannot be confirmed through specific tests, but it's diagnosed by ruling out other causes of dementia. Definitive diagnosis is only possible after death via autopsy. The presence of neurofibrillary tangles, which are thickened neurofilaments surrounding and obscuring nerve cell nuclei, as well as neurological plaques, or these clusters that are formed by dead neurons, and then senile plaques, or accumulations around certain proteins. Pre-hospital care is going to primarily focus on supportive management and addressing the symptoms. Use slow, clear communication and assess for any other illnesses. If the patient becomes combative or poses a danger, antipsychotics or benzodiazepines may be considered. These medications should be used only if verbal escalation techniques fail. Daily medications for Alzheimer's may include things like antidepressants, cholinesterase inhibitors to slow the further decline, memantine and galimantine, which might also be prescribed. No single cause of Alzheimer's disease has been identified, and it is not considered a normal part of aging. Age is a major risk factor, but other factors are often contributive to leading down the path of Alzheimer's. Parkinson's disease is a neurological disorder associated with aging, and it's characterized by 2 or more of the following symptoms: tremors and resting extremity, slowed movements, stiffness or rigidity in the limbs or trunk, and impaired balance. Parkinson's disease can involve one or both sides of the body and causes a broad range of functional impairments. And those symptoms may include dyskinesia, dementia, depression, anatomic dysfunction, postural instability. The pre-hospital treatment for Parkinson's disease is talked about more in depth in Chapter 19 in Neurological Emergencies, so refer to that chapter for further information. Seizures occur more frequently in older adults, partly due to an increased number of risk factors such as stroke, dementia, brain tumors, and metabolic disorders. Pre-hospital treatment is going to be for the same for both younger and older patients, so there's no distinction or difference there between the two. All right, moving on to the last section of part 3 is going to be GI conditions. So constipation it makes the top of the list with issues GI related. It's a common issue in older adults, but it should not be the first diagnosis when patient reports acute abdominal pain. You know, we talked about earlier in this chapter how the slower motility through the digestive tract oftentimes leads to constipation, but we shouldn't always make that assumption. Yes, older people have, lose some visual abilities and some hearing abilities, but never make the assumption that that's the case with the patient that you have. So it's the same with this. If they're reporting abdominal pain, we want to rule out other high mortality causes, such as bleeding from an aneurysm or bowel necrosis due to a mesenteric ischemia or something along those lines, rather than just jump to conclusions and assume that we're dealing with a simple constipation issue. When evaluating a gastric emergency, be sure to ask about fluid and food consumptions, past abdominal issues that they've had, current bowel and bladder patterns, medications and supplements that they're taking. Symptoms frequently present as vague or non-specific, and they kind of feel it all over. Abdominal pain may sometimes indicate a cardiac condition as well. Many abdominal or gastric complaints often need surgical intervention. Bowel obstructions in older adults, large bowel obstructions are commonly caused by things such as cancer or just simply impacted stool. There could be a sigmoid volvus or something along those lines going on. In the small bowel, obstructions are caused by gallstones becoming more common with age. Repeated episodes of cholecystitis can cause gallbladder to adhere to the small bowel, forming a fistula, and a gallstone may then pass into the bowel and cause an obstruction. Large and small intestinal obstructions may result from adhesions caused by previous surgeries or infections. It could be caused by a current infection. It could be a fascicle defects in the abdominal wall or a hernia. Could be caused by diet or the addition of new medications or the prolonged use of particular medications. Gastroesophageal reflux disease, or GERD, is common among older adults as well. Patients with GERD usually know how to manage their symptoms. GERD symptoms may sometimes indicate a more serious cardiac condition, though. Always perform a 12-lead EKG and transport the patient for further evaluation if they've called you for GERD symptoms. Biliary disease may occur with or without small bowel obstruction in older adults and includes conditions such as cirrhosis, hepatitis, and cholecystitis. Signs and symptoms may include jaundice, which may be more noticeable in patients with lighter skin. Fever might be less obvious in older patients, and pain in the upper right quadrant that can radiate to the upper back or shoulder, as well as nausea and vomiting. Pain management may be needed for acute cholecystitis, but use caution with opiates in older adults due to their reduced ability to tolerate cardiovascular and respiratory effects caused by these drugs. Peptic ulcers. When it comes to peptic ulcers, older adults are more likely to develop stomach and duodenal ulcers that we commonly refer to as peptic ulcer disease. Main risk factors are going to include regular use of NSAIDs such as ibuprofen, infection or Helicobacter pylori infections, some medications, even social factors like high stress occupations, and then just certain personality traits are more prone to this. Dyspepsia is the primary symptom, usually improving immediately after eating or returning hours later. Other causes of dyspepsia are going to include acid reflux, gastritis, and gastric cancers. GI bleeding is more common in older adults, and it usually results from normal physiological changes or diseases affecting the digestive system. Aging slows the body's ability to stop bleeding due to that reduced vascular tone that we've talked about and thinner epithelial tissues. Slower peristalsis raises the chances that irritating substances will harm the stomach lining. Common medications also affect blood clotting, including warfarin, aspirin, and heparin. Gastrointestinal conditions that lead to bleeding include ulcers and varices, cancers of the stomach, esophagus, colon and rectum, diverticulitis, cirrhosis, and bowel obstructions. Sources of bleeding can differ, but signs and symptoms depend more on the bleeding location than the cause. Bleeding from the esophagus is most often linked to varices and alcohol use disorder. Violent vomiting with little to no food and large amounts of bright red uncoagulated blood is commonly what is seen. Bleeding from the stomach, on the other hand, is commonly associated with peptic ulcer disease, and the vomiting may be red or resemble more of a coffee ground type of look because it's partially digested. Bloody stools indicate bleeding from the lower intestinal tract, although blood in the stomach may be digested, causing the stool to appear dark and really tarry black looking. Bright red stool in the blood usually originates from the large intestine or rectum and may be caused by diverticulosis, large bowel obstruction, anal fissures, or hemorrhoids. The darker the blood, the greater the distance between the bleeding site and the exit point, which is a good rule of thumb to remember. Upper gastrointestinal hemorrhage is bleeding from the esophagus, stomach, or duodenum. Older adults are more susceptible to upper GI bleeding and often require emergency surgery when this is present. They face higher risk factors of complications and mortality. The cause cannot be identified without endoscopic examination. Obtain a detailed history and look to find clues, like the regular use of NSAIDs or alcohol consumption that can lead to bleeding from irritated linings or ulcers in the duodenum or stomach. Maybe forceful vomiting that may result in esophageal tears. Liver cirrhosis can cause esophageal varices, which may rupture and cause severe bleeding. Stomach or esophageal cancers can cause upper respiratory or upper GI bleeding as well, not respiratory, GI bleeding, upper GI bleeding. Lower gastrointestinal hemorrhage involves bleeding from the colon or the rectum. Don't assume bleeding is from hemorrhoids. It may also originate from colon polyps or cancers. Minor lower GI bleeding appears as small amounts of red blood in formed stools or toilet paper. Severe GI bleeding involves large amounts of red blood or maroon-colored stools, and it typically will change the entire color of the water where the stool is located. Risk factors are going to include a history of previous GI bleeding, signs or symptoms of colon cancer, recent constipation or diarrhea, and use of medications such as blood thinners and those kinds of things. Treat the patient for shock if they're in shock. If H&H levels drop significantly during transport, which we're not going to know about, hemoglobin hematocrit levels, they may need a blood transfusion when they arrive at the hospital. Severe lower gastrointestinal bleeding demands urgent transport. Signs and symptoms of gastrointestinal bleeding are linked to hypovolemia and include agitation, dizziness, fainting, low blood pressure, altered mental status. Signs and symptoms related to the underlying disease may also include yellowing of the skin or eyes, enlarged liver, constipation and diarrhea, pain during urination, nausea, and abdominal pain. Assessing the severity of bleeding is more important than identifying the cause. Slow bleeding often shows as dark coffee ground vomiting. Pulse rate and systolic blood pressure usually remain normal in slow bleeding. However, rapid bleeding presents with vomiting blood or black tarry stools. Black tarry stools is more common symptom than any kind of pain in brisk bleeding. Pre-hospital care is going to be supportive and includes managing pain. Treatment's going to focus on recognizing and managing hypovolemic shock and transporting the patient to a facility that's capable of delivering definitive care. All right. So that is part 3. Yeah, part 3 of chapter 45. I will see everyone back, or you'll hear me back. One of the two. I probably won't see you, but you'll hear me back at part 4.